morning, one and all. Today we will start with vascular retinopathies. In the previous class, I have covered anatomy of retina and vascular disorders of the retina like retinal artery occlusions and retinal venous occlusions. So today we'll deal with vascular retinopathies. What are vascular retinopathies? These are a group of disorders occurring as a part of systemic diseases like hypertension, diabetes, and toxemia of pregnancy. Usually, it is associated with changes in the retinal vessels reflecting vascular status of other tissues such as brain and kidney. The retinal changes, they originate from a state of anoxia, which results in increased permeability of the capillaries and formation of microaneurysms and local degenerative changes in the retinal tissues. So first, today we'll deal with diabetic retinopathy. We'll discuss about diabetic retinopathy under the following subheadings. So first, coming to introduction. So what is actually diabetic retinopathy? It is involvement of retina in a patient with diabetes. So why is diabetic retinopathy so important? It is important because it is the leading cause of blindness among patients aged 20 to 74 years. And also, ophthalmologists may be the first to diagnose diabetes mellitus in some patients. And the timely intervention and early detection can save the vision of the patient. And also, it is the commonest category of patients attending the retina clinic of about 400 in 1100 patients. So what are the various risk factors for diabetic retinopathy? The main important risk factor is duration of diabetes. So the incidence of diabetic retinopathy after 10 years is 20% in type 1 diabetics and 25% in type 2 diabetics. Whereas after 30 years of duration of the onset of diabetes, the incidence is about 95% in both type 1 and type 2 diabetics. In type 1, they rarely develop retinopathy within first 5 years of onset. Whereas type 2 diabetes mellitus, about 5% of the patients, they have diabetic retinopathy at the presentation of disease. And after 20 years of diabetes, almost all type 1 patients and more than 60% of the type 2 patients, they present with some degree of diabetic retinopathy. The other risk factor is type of diabetes. So, type 1 diabetics, because the duration of diabetes is more in them, type 1 diabetics are more prone to develop diabetic retinopathy when compared to type 2 diabetic patients. And also in type 1 diabetics, the incidence of PDR, that is proliferative diabetic retinopathy, is more common. Whereas in type 2 diabetic patients, macular edema is more common. The other risk factors are poor metabolic control. Though this is not very significant, but intensive glycemic control shows that it can delay the onset and progression of diabetic retinopathy. So it reduces the incidence of severe NPDR and PDR and the need for laser by about 45%. Other risk factors are pregnancy. So in patients with diabetics and no retinopathy, because of pregnancy, there can be increased incidence of retinopathy by about 8%. And in patients with NPDR, there is progression into PDR by 4%. In some cases, after delivery, the changes of retinopathy, they regress and everything becomes normal. The other important risk factor is coexisting risk factor is hypertension. Mainly systolic hypertension is associated with increased progression of diabetic retinopathy and development of diabetic macular edema. The other systemic risk factors are anemia, hyperlipidemia, obesity, and cigarette smoking. Nephropathy, when present with elevated BUN, proteinuria, and increased creatinine, all these are excellent predictors of diabetic retinopathy. If these three are present, then diabetic retinopathy generally progresses from NPDR to PDR, and if we control the renal disease, there is improvement of diabetic retinopathy and better response to treatment is also present. with the correction of the renal disease. And cataract surgery sometimes can also lead to progression of macular edema. Next, coming to pathogenesis of diabetic retinopathy. So the exact mechanism is not known, but exposure to hyperglycemia over an extended period leads to certain changes in the vascular endothelium. So these are called microangiopathy. That is, it affects the retinal precapillary arterioles, capillaries, and venules. So it leads to microangiopathy because of cellular damage and hematological changes. So what is the cellular damage? The capillaries are damaged because of accumulation of sorbitol. Why does sorbitol get accumulated? Because there is increase in the amount of glucose by aldose reductase mediated glycolysis. The glucose is converted into sorbitol, and this leads to increase in the osmotic gradient, and osmosis occurs, leading to cellular damage. And other mechanisms of cellular damage are there is accumulation of advanced glycation end products and free radical mediated oxidative stress, and also there is excessive activation of protein kinase C and diacylglycerol. So these are the factors for cellular damage. One is increase in the sorbitol, other one is advanced glycation end products, protein kinase C, and free radical mediated oxidative stress. Next, coming to hematological changes. So what are the various hematological changes you see with hyperglycemia? There is RBC roller formation and increased platelet adhesiveness. That is hyperviscosity of the blood leading to occlusion of the vessels. And also there is abnormal serum lipids and increased leukostasis because of increased in the expression of ICAM1, that is intracellular adhesion molecule 1. Because of this, there is leukostasis, means increased aggregation of the WBCs in the blood vessels. And also there is increase in the fibrinolysis. By these both the cellular changes and hematological changes, hyperglycemia leads to microangiopathy. So microangiopathy means small blood vessels like precapillary arterioles, venules, and capillaries. So what happens with this microangiopathy? It can cause two effects, either occlusion or leakage. So occlusion is mainly because of capillary changes and hematological changes, whereas microvascular leakage is because of capillary changes. So first we'll deal with microvascular occlusion. So what are the capillary changes you see? Here you can see this is the capillary. This is also the capillary, and what are these pericytes? These pericytes, they surround the vascular endothelium, and in diabetes we see loss of the pericytes and thickening of the basement membrane, and there is damage and proliferation of the endothelial cells. Because of the microvascular occlusion, there is retinal ischemia and hypoxia. Because of decrease in the blood supply, there is hypoxia of the retinal tissue. So to restore blood supply, what happens? There is development of the arteriovenous shunts. And also there is increased expression of vascular endothelial growth factor, leading to occurrence of neovascularization. So this neovascularization can be present in the disc, elsewhere, or in the iris. Where it is present in the iris, it is called rubeosis iridis. So microvascular occlusion is because of capillary changes like loss of pericytes, thickening of the basement membrane, and damage and proliferation of the endothelial cells. So this leads to hypoxia of the retina, leading to occurrence of AV shunts and release of VEGF factors, that is vascular endothelial growth factor, which leads to neovascularization. Next, coming to microvascular leakage. So what happens here is, as already mentioned, in the capillaries there is loss of the pericytes. So there is less support to the endothelial wall. So what happens? There is loss of the vessel wall integrity and distension of the capillary walls. It leads to saccular outpouchings. So these are called microaneurysms. So because they are distended and thinned out, there is breakdown of the blood retinal barrier. So whenever there is breakdown of a barrier, it leads to release of transudits and exudates. So because of accumulation of transudits, it causes retinal edema, and intraretinal hemorrhages as well as hard exudates occur. So before dealing with the per se what features are seen in diabetic retinopathy and how you classify diabetic retinopathy, I'll briefly describe some important findings we see in retinal disorders. So first we'll deal with microaneurysms. As already mentioned, these are saccular outpouchings of the retinal capillaries because of pericyte loss. And in diabetic retinopathy, this is the earliest detectable change and it is present temporal to the fovea. How do they appear? They appear as tiny round red dots and they are present at the venous end of the capillaries. On FFA, we can see early hyperfluorescence with late leakage. So this is normal capillaries and here you can see loss of the pericytes and these are microaneurysms. You can see saccular outpouchings. So this is the fundus picture. You can see tiny red dots temporal to the fovea. And on FFA, what is FFA? Fundus fluorescein angiography. It is a technique used to demonstrate the blood circulation in the retinal capillaries, vessels, both arteries as well as veins and choroidal circulation. So what you see in fundus fluorescein angiography, that is FFA, is there is small leakages present from the microaneurysms because these capillary walls they get thinned out, so they can't act as a good barrier. So there will be leakage of the dye from the microaneurysms leading to small hyperfluorescent spots. Next important features we see in retinopathies is hemorrhages. In hemorrhages, there are two types of hemorrhages, superficial and deep. So what is deep hemorrhages or intraretinal hemorrhages? These hemorrhages, they occur in the inner nuclear layer. So if you recapitulate, what are the structures present in the inner nuclear layer? It contains bipolar cells, molar cells, hemacrine cells. So because it is deeply located and here the fibers, they are compact in nature, the hemorrhage, the blood cannot spread easily. So the spread of the blood is contained and they appear as dot and blot hemorrhages. Whereas in the superficial hemorrhages, here the hemorrhages occur in the nerve fiber layer. Here the nerve fibers, they are loosely arranged, so there is dispersion of the blood more, leading to flame-shaped appearance at the superficial layer. So these are dot and blot hemorrhages and these are flame-shaped superficial hemorrhages. So anywhere if we see flame-shaped hemorrhages, it indicates superficial hemorrhages. That is in the nerve fiber layer. And dot and blot hemorrhages, they are present in the inner nuclear layer. So this is also another picture showing hemorrhages. This is microscopic structure. We can see both deep as well as superficial hemorrhages. So these are superficial hemorrhages and these are deep dot and blot hemorrhages. And the other characteristic findings we see are soft exudates and hard exudates. So what are soft exudates? These are small whitish fluffy superficial lesions. They are caused due to infarction of the retinal nerve fiber layer because of axoplasmic stasis. So they have indistinct fuzzy margin. Here you can see they are white fluffy with indistinct margin. So these are called soft exudates or cotton wool spots. Because of their appearance, they are called cotton wool spots. And next is hard exudates. This is collection of lipid-filled macrophages. In contrast to soft exudates, they have distinct margin. You can see the borders clearly and distinctly. And they are mostly arranged in clumps or circinate pattern and mostly they are concentrated at the macula. For both the soft and hard exudates on FFA, we see blockage of the background choroidal fluorescence. In diabetic retinopathy, another important feature is intraretinal microvascular abnormalities. These are arteriovenous shunts which bypass the capillaries. We see fine red lines from the arterioles to venules. So we can see here fine lines. So these are called. So this is a branch of the artery and this is the branch of the vein. Here you can see fine red lines which are connecting the artery and the vein. So these are called IRMA. What is the distinguishing feature between IRMA and neovascularization is these are more located within the layers of the retina and they do not cross the major retinal blood vessels and there is absence of leakage on FFA. So these are intraretinal microvascular abnormalities. So this is a branch from the artery and this is from the vein and you can see a communication. The next thing is retinal edema. It is initially present between the outer plexiform and inner nuclear layer. Later, it reaches up to the nerve fiber layer. On FFA, we see hyperfluorescence. Other venous changes we see are venous looping, beading, and dilatation. We see the lumen is more broad when compared to the normal size, and we see looping as well as beading of the veins. So these are the main characteristic features present in retinopathies. Microaneurysms, hemorrhages, they are soft exudates and hard exudates. In hemorrhages, we have superficial and deep hemorrhages. So now we'll classify diabetic retinopathy. The important classification of diabetic retinopathy is by ETDRS. So early treatment of diabetic retinopathy study has classified diabetic retinopathy into 4 types. Non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, maculopathy, and advanced diabetic eye disease. So first we'll deal with NPDR. In NPDR, again it is classified into 4 types: mild, moderate, severe, and very severe, depending upon the presence of microaneurysms, hemorrhages, and other IRMA and venous bleeding. So what is mild NPDR? Here, at least one microaneurysm or intraretinal hemorrhages must be present, at least one. Hard and soft exudates may or may not be present. Next, coming to moderate NPDR. Here, there are moderate microaneurysms and intraretinal hemorrhages. Similar to mild NPDR, hard exudates and soft exudates may or may not be present, and early mild IRMA, that is intraretinal microvascular abnormalities, are present. Coming to severe NPDR. Here we have to apply 4-to-1 rule. If any one of this is present, it indicates severe NPDR. So what is this 4-to-1 rule? 4 quadrants of severe microaneurysms and hemorrhages, 2 quadrants of venous bleeding, and 1 quadrant of IRMA changes. So this is 4-to-1 rule. If any one of this present, it's called severe NPDR. Then what is very severe NPDR? Similar 4-to-1 rule is applied, but instead of 1, at least 2 of this must be present, and it is called very severe NPDR. So in NPDR, we have 4 classes: mild, moderate, severe, and very severe. So this is a picture showing mild NPDR. It is actually at least one microaneurysm must be present. So here you can see multiple microaneurysms. Hard and soft exudates may or may not be present, and in this picture there are no exudates. Next, coming to moderate NPDR. Moderate hemorrhages and microaneurysms. So these are dot and blot hemorrhages, and these are microaneurysms, and you can see soft exudates. Early mild IRMA can be present. So that is moderate NPDR. Next, coming to severe NPDR. So in severe NPDR, we have 4-to-1 rule. So all the 4 quadrants, there are hemorrhages and exudates. And you can see venous bleeding and venous looping here. So 2 quadrants of venous bleeding is present. So this is venous bleeding, and this is just dilatation. So this is venous bleeding is present, but if for severe, at least 1 should be present. So 4 quadrants of hemorrhages and exudate. If similar bleeding is present in 2 quadrants, then it is called very severe. So NPDR is completed. Next we have PDR, that is proliferative diabetic retinopathy. It affects about 5 to 10% of the diabetic population, and insulin-dependent diabetics are at more risk of developing proliferative diabetic retinopathy. And the risk of NPDR progressing to PDR within 1 year is 15% in the severe NPDR and 45% in very severe NPDR. That means in severe NPDR stage, 15% of the cases can progress to PDR within 1 year. Whereas in very severe NPDR, about 45% of the cases can develop PDR within 1 year. This is based on ETDRS study. So what are the features of proliferative diabetic retinopathy? The main hallmark is neovascularization. So there are new vessels either at the disc or anywhere else of the retina, or new vessels at the iris. As I already said, new vessels at the iris is also known as rubeosis iridis. And the other features are vitreous detachment with fibrovascular proliferation and only vitreous hemorrhage or pre-retinal hemorrhage. So this is a fundus image showing proliferative diabetic retinopathy. So what features we see here? These are deep hemorrhages and these are superficial hemorrhages. These yellow ones are hard exudates. So if all these are present, it indicates severe NPDR and very severe NPDR. So how do you say this? That it is a proliferative diabetic retinopathy. Here you can see new vessel fronts. So this is a neovascularization. And here also on the disc you can see neovascularization. And also you see a fibrous tissue attached from the disc extending into the vitreous. So presence of neovascularization and fibrous tissue proliferation is a hallmark of PDR. So this is neovascularization. Here you can see new vessel arising from the branch. This is also neovascularization formed. This is neovascularization along with fibrosis. And on FFA, in contrast to IRMA, so we can get confused between IRMA and neovascularization, because similar to IRMA, these are also appearing as shunts between the arterioles and venules. So how do you differentiate between IRMA and neovascularization? Is that here on FFA, these neovascularization, because the endothelial wall is not completely formed, they leak fluorescein dye profusely. And also these are more superficially located, whereas IRMA they are deeply located. Because of microvascular occlusion, there is retinal ischemia and hypoxia leading to release of vasoproliferative substances, and the endothelium proliferation especially starts from the venous end. These they pass through the defect in the internal limiting membrane. This is called retina mirabile between the retina and posterior vitreous face. Because at the optic disc, the internal limiting membrane is very thin. Here it is manifested easily, and that is called retina mirabile. So what is the stage of evolvement of new vessel? Initially there are fine new vessels with minimal fibrosis. Later there is increase in both vessel as well as fibrosis. Later there is regression of the new vessel, leaving only fibrovascular proliferation behind them. So this can lead to fractional retinal detachment or hemorrhages. For PDR to develop, at least 1/4 of the retina must be non-perfused. That means 1/4 of the retina should be hypoxic for development of new vessels. PDR is again classified into two types: without high-risk characteristics and with high-risk characteristics. Without high-risk characteristics is called early PDR, and with high-risk characteristics is called advanced PDR. So what are these high-risk characters? NBD of 1/4 to 1/3 disc area with or without vitreous hemorrhage. When the neovascularization of the disc is less than 1/4 to 1/3 along with or without vitreous hemorrhage, it is called high-risk characteristic. And neovascularization of the disc less than 1/4 with vitreous hemorrhage, it is called high-risk characteristic. And NBE, that is neovascularization elsewhere, when it is more than half disc area with vitreous hemorrhage, it is called high-risk characteristics. So when high-risk characteristics are present, we have to aggressively treat the patient. So next stage of classification of diabetic retinopathy is diabetic maculopathy. So this is involvement of the macula by edema and hard exudates, and sometimes ischemia can also be present. It is the most common cause of visual impairment in type 2 diabetic patients. So why is edema occurring? It is because of dilatation of the capillaries and disruption of the capillary wall. Previously, I have showed that when there is disruption of the capillary wall, the blood retinal barrier is lost, so there will be exudation and edema of the retinal tissue. When this occurs in the macula, it is called diabetic maculopathy. So how do you classify diabetic maculopathy? It is classified into focal exudative, diffuse exudative, and mixed maculopathy, ischemic maculopathy, and clinically significant macular edema. So what is focal exudative maculopathy? Here you can see circumscribed retinal thickening is present and associated incomplete hard exudates are present. So it is localized only to this part of the macula. So this hole is macula, and you can see only focal thickening of the macula along with hard exudates. So this is called focal exudative maculopathy. And what you see on FFA, there is leakage on FFA. What is diffuse exudative maculopathy? Here there is diffuse retinal thickening and we cannot delineate the borders of macula. In FFA we see diffuse leakage, generalized leakage is present. Coming to ischemic maculopathy. So what is ischemic maculopathy? Because of occlusion of the vessels, there is decreased blood supply to the macula. Here the macula, it generally appears normal. Sometimes there can be dark blood hemorrhages present in the macular area. FFA is characteristic for ischemic maculopathy. We see the enlargement of the foveal avascular zone. Here you can see there is no perfusion. This all is hypofluorescence, and this indicates that there is no circulation of the in the blood vessels. So it leads to ischemic maculopathy. Mixed maculopathy means it has both the characteristic of exudative and ischemic maculopathy. And next important thing is clinically significant macular edema. So what is this CSMA? It occurs in 3 conditions. When the retinal edema, so this grayish spot is retinal edema. If retinal edema is present within 500 micrometers of the center of the fovea, then it is called CSMA. Or when the hard exudates are present within 500 microns of the fovea and adjacent retinal thickening must be present. Even if this adjacent retinal thickening is outside the limit of 500 microns, if hard exudates are present within the 500 micron limit, then it comes under CSMA. Another condition which is also categorized under CSMA is retinal edema must be of about 1 disc area or larger. See, this is almost more than the size of the optic disc. So, retinal edema of either 1 disc diameter or more than 1 disc diameter, and a part of it must be within 1500 microns from the center of the fovea. So, this circle is drawn with a radius of 1500 micrometers. So, retinal edema of 1 disc diameter or more with any part of which is located within 1500 micrometers from the center of the fovea. So, that is maculopathy. So, diabetic maculopathy, we have 5 classifications: focal exudative, diffuse exudative, and ischemic maculopathy, mixed maculopathy, and CSMA. So, the next classification is advanced diabetic eye disease. When there is uncontrolled proliferative diabetic retinopathy, it leads to either hemorrhage. It can be pre-retinal or intravitreal, and it can also lead to retinal detachment. Then it can be non-regmatogenous. That means when it is not associated with a retinal break, or it can be regmatogenous. That means it is associated with a retinal break, or it can also lead to neovascular glaucoma. So this is vitreous hemorrhage, and this is a pre-retinal hemorrhage, and this is retinal detachment. You can see wavy outlines of the retina instead of the normal purplish red hue of the retina. You see retina is white in color because it is detached from the posterior artery. So these are the characteristic features we see in advanced diabetic eye disease. So what is this picture showing? You can see a boat-shaped pre-retinal hemorrhage. and this is vitreous hemorrhage. And this is, we can see, fractional retinal detachment. This is a fibrovascular band which causes detachment of the retina. And in this picture, you can see iris. There are new vessels proliferating on the surface of the iris. So this is called rubeosis iridis. All these features are clubbed together into advanced diabetic eye disease. So until now, we have dealt with what is diabetic retinopathy, what are the various risk factors of diabetic retinopathy, and what is the pathogenesis of diabetic retinopathy, and how do you classify diabetic retinopathy. So the risk factors are duration, the type of diabetes based on the glycemic control, associated hypertension, pregnancy, and smoking, anemia, obesity. All these are main risk factors. Out of this, the major risk factor is duration of diabetes and the type of diabetes. Coming to pathogenesis, it is mainly due to hyperglycemia leading to microangiopathy because of cellular damage and hematological changes. So microangiopathy can lead to microvascular occlusion and microvascular leakage. Because of occlusion, we get manifestations like microaneurysms, cotton wool spots, etc. Because of edema, microvascular leakage, we have features like hard exudates and retinal edema. Coming to classification, it is classified into NPDR, PDR, diabetic maculopathy, and advanced diabetic eye disease. And NPDR is again classified into 4 types: mild, moderate, severe, and very severe. PDR is classified into 2 types, with high risk and without high risk characteristics. Diabetic maculopathy is classified into 5 types: focal exudative, diffuse exudative, ischemic maculopathy, mixed maculopathy, and CSL, clinically significant macular edema. And the last stage is advanced diabetic eye disease, and in that we have retinal or vitreous hemorrhage, and retinal detachment, and neovascular glaucoma. So what are the various causes of vision loss in patients with diabetic retinopathy? As already mentioned, macular edema and macular ischemia are major cause of vision loss in patients with diabetic retinopathy. And vitreous hemorrhage or retinal hemorrhage, fractional or combined detachment can also lead to vision loss. So until now, a patient has come with you with vision loss, and you have assessed the patient that he is having diabetic retinopathy. So now what we have to do with such patient? We have to successfully manage diabetic retinopathy by doing early, aggressive, and consistent control of the blood glucose level. We already have studied that by controlling the blood glucose level, we can delay the onset and progression of diabetic retinopathy. So we have to advise the patient strict glycemic control, and regular dilated fundus examination is necessary, and timely and appropriate management plays a very important role to restore the vision in patients with diabetic retinopathy. So these are the various trials conducted in diabetic retinopathy: DRS, ETDRS, DRES, DCCT trial, and UKPDS trial. So coming to the medical management of diabetic retinopathy. So good glycemic control reduces the progression, and associated hypertension should also be corrected. And in patients with advanced renal disease and anemia, these should also be corrected. As I already told, renal disease, when corrected, it helps in the recovery of diabetic retinopathy, and also the response of patients with to laser is also better when the renal disease is corrected. So that is medical management or the systemic management of the patient. Now coming to ocular management of the main diabetic retinopathy. So what are the various treatment modalities we have? One is laser photocoagulation. It is either pan-retinal photocoagulation or focal or grid photocoagulation. And other treatment modalities are intravitreal triamcinolone acetonide, intravitreal anti-VEGF, and bevacizumab, and vitrectomy. So first we'll deal with laser photocoagulation. So what is the indication for laser photocoagulation? Previously, it was indicated for all cases, but now with the advent of anti-VEGF and steroids, the use of laser photocoagulation is decreased, and it is reserved for patients with high risk PDR. That is, when NVD is more than 1/4 to 1/3 with or without vitreous hemorrhage, 1/4 to 1/3 with or without vitreous hemorrhage, and NVD is less than 1/3 with vitreous hemorrhage, and NVE more than half with vitreous hemorrhage. So all these are high risk characteristics PDR. In all such cases, we have to advise laser photocoagulation. Similarly, in patients with severe and very severe NPDR. So when do we suggest laser for such patients? When the patient is not able to come for regular follow-up, or the patient has already renal disease, or patient is already having severe diabetic eye disease or advanced diabetic eye disease in the other eye. In such patients, for severe and very severe NPDR also, we have to suggest laser photocoagulation. Another important indication is clinically significant macular edema. So how does this laser photocoagulation act? The exact mechanism is unknown, but it acts by decreasing the production of vasoproliferative factors and eliminating some of the hypoxic retina. And it also stimulates the release of anti-angiogenic factors from the RPE. And another important mechanism is by coagulating the retina, the retinal layers become thin. So there is increased oxygenation of the remaining retina. So it decreases the need for vasodilatation and endothelial cell proliferation. So we have two types of laser photocoagulation techniques available. One is pan-retinal photocoagulation, and another one is for macular lesions, focal or grid laser photocoagulation. So what is pan-retinal photocoagulation? The name itself suggests pan-retina means entire retina is photocoagulated with the help of laser. So this produces destruction of ischemic retina, which is responsible for the production of vasoformative factors. So the indications are already mentioned: PDR with high risk, NDI, and severe NPDR with poor compliance. So how is this laser photocoagulation, pan-retinal photocoagulation done? Here, laser burns. So all these green dots are laser burns. They are applied about 2 to 3 disc areas from the center of the macula. From the center of the macula, it is 2 to 3 disc diameters away, peripherally up to the equator. How many spots are applied? About 1200 to 1600 spots are applied. How are they applied? They are applied one burn width apart. What is the size of this burn? It is about 500 microns. So how much duration laser we have to give? It is 0.1 second duration. So 1200 to 1600 spots, 500 micron size, 0.1 second duration, and one burn width apart around the macula of 2 to 3 disc areas up to the equator. So the main goal is to reduce the neovascular tissue. So which lasers are used for PRP? We can use either argon green laser, diode laser, or NDR laser. So next, coming to macular photocoagulation. We can give macular photocoagulation either focal or grid type. This is indicated in patients with CSME. In ischemic maculopathy, we should not do laser photocoagulation because already the tissue is ischemic there. By doing laser, again we are converting it into more ischemia, so the patient develops more vision loss when we do laser in ischemic maculopathy. So there are two types of treatment: focal and grid. Next, coming to pars plana vitrectomy. So the indications for pars plana vitrectomy are when the vitreous hemorrhage is dense and non-clearing, or there is fractional retinal detachment involving the macula, or when there is both combined regmatogenous as well as fractional RT, and diabetic macular edema is present with posterior hyaloid traction, or when there is recurrent vitreous hemorrhage despite doing maximal pan-retinal photocoagulation, and anterior segment neovascularization is present with the media opacity, because of which we are not able to do PRP, or when there is red blood cell induced glaucoma. So all those are indications for vitreous hemorrhage. And next, intravitreal injection of triamcinolone acetonide. So what is the main action of triamcinolone? So this is a steroid, as you all know. So how does it act? It acts by inhibiting the release of VEGF and other cytokines and growth factors, and it regulates the tight endothelial cell junctions, so it restores the blood retinal barrier. Thus, it decreases the amount of edema and exudation. So how do you give the injection? It is given in the infratemporal quadrant so that the drug is not deposited in front of the visual axis. About 0.1 ml of the drug, that is 4 mg of triamcinolone is given. So what is the main important complication with triamcinolone? It can cause either cataract or glaucoma, and because of intravitreal procedure, we can lodge some infection. It can lead to endophthalmitis. So other drugs which we can give intravitreal are anti-VEGFs. Anti-VEGF means vascular endothelial growth factor. So the main anti-VEGFs used are bevacizumab and ranibizumab. So bevacizumab dosage is 1.25 mg in 0.1 ml, and bevacizumab is ranibizumab is 0.5 mg in 0.1 ml. So these the name itself suggests anti-VEGF. So it acts by decreasing the VEGF factors and helps in stabilization of the vision and decreasing the edema. So the indications are focal CME when there is center of the fovea involvement, diffuse diabetic macular edema, diabetic macular edema with neurosensory detachment, and in patients with PDR whom we are performing PRP. In such patients, we can give first anti-VEGF and then later we can do PRP. So that is the various treatment modalities we have for diabetic retinopathy. So actually when a patient is diabetic, he knows that he is diabetic. So when he must come to ophthalmologist for checkup, so depending upon the age of the onset. If the age of the onset of diabetes is 0 to 30 years, then the first eye examination must be done within 5 years of diagnosis. And how should we follow up the patient? Every yearly. Annually, we have to examine the patient for development of any retinopathy. If the age of onset is more than 31 years, generally it indicates type 2 diabetes. So, as already mentioned, in type 2 diabetics, almost 5% of the patients, they have retinopathy at the time of diagnosis of diabetes. So, in such patients, fundus examination is done immediately at the onset of diabetes, and follow-up should be every yearly. In case of pregnancy, sometimes gestational diabetes is present. In such patients, we have to examine the fundus in the first trimester and then later every 3 months or at the discussion of the ophthalmologist. So how do you follow up a patient with already when the patient has developed retinopathy? How do you follow? So this is how we follow a patient with diabetes, and when there is no retinopathy, how do you follow a patient? And this table, it gives you the idea of how to follow a patient after diabetic retinopathy has developed. When it is mild NPDR, then you have to examine the patient every 9 months. When there is moderate NPDR, we have to examine every 6 months. When it is severe NPDR, we have to examine every 4 months. And when it is CSME, clinically significant macular edema, we have to examine the patient every 2 to 4 months. And in patients with PDR, we have to examine the patient every 2 to 3 months. So this is the protocol we follow generally for patients with diabetic retinopathy. So aggressive treatment and management of diabetic retinopathy is very important so that the patient restores or regains his lost vision. So that is the, with this we complete diabetic retinopathy. So we have discussed all the important features of classification, pathogenesis, and treatment modalities. So the treatment modalities are intravitreal injections, laser, and vitrectomy. Intravitreal injections are steroids and anti-VEGFs. Diabetic retinopathy sometimes can be an essay question for you, but generally it is covered in 4 marks question, short answers, and Diabetic retinopathy is important PG bits. So many of the PG bits are from diabetic retinopathy. From the topic retina, most bits they come from diabetic retinopathy. So I have discussed diabetic retinopathy full extensively so that you will not have any confusion. I think I'm clear with the diabetic retinopathy. If you have any doubts, you can ask. If you don't have any doubts, I will just want to Okay, so if you don't have any doubts, I will ask you a few questions from the previous class of retina about the anatomy of retina and vascular disorders. So, mm, what is the first order neuron in the retina? Anyone can answer, or if you want me to mention any particular number, I'll mention. Anyone can answer what is the first order neurons in retina. How many layers are there in the retina? Okay, very good. Who is this 108? What is the name? Tell your name 108. Meena. Okay, very good. And where do you see cherry red spot? In which conditions do you see cherry red spot? Central retinal artery occlusions. And other conditions? Where in central retinal artery occlusion we see cherry red spot. What are the other conditions where we see cherry red spot? It is Tay-Sachs disease and gangliosidosis, GM1 gangliosidosis, Tay-Sachs, all these cases you see cherry red spot. Okay. Cattle truck phenomenon is seen in which disease? In which retinopathy? Cattle truck phenomenon. So we are not attentive in the last class. The cattle truck phenomenon is seen in central retinal artery occlusion because there is segmentation of the blood in the retinal veins. We see cattle truck appearance. Segmentation of the blood in the retinal veins as columns is called cattle truck appearance. What are the types of central retinal vein occlusion? What are the types of central retinal vein occlusion? Ischemic and non-ischemic. So what are the other names for ischemic and non-ischemic retinal vein occlusions? Which is hemorrhagic and which is venous stasis retinopathy? Okay. Okay, I'll come to anatomy back now. What is the shape of the optic disc? Vertically oval. What is the size of the optic disc? When you are mentioning it as vertically oval, how can we give only one diameter? It must be both horizontal and vertical. No? Horizontal is 1.76 and vertical is 1.86. Okay. 1.5 to 1.7 and 1.8. Okay. And why is optic disc also known as physiological blind spot? Why is optic disc also known as physiological blind spot? I am asking this question. I am thinking of knowing that all of you know optic disc is also known as physiological blind spot. Yes, here there is absence of photoreceptors. So it casts as photoma in the visual field. So it is called physiological blind spot. Which part of the retina has highest visual acuity? Which part of the retina has highest visual acuity? Yes, very good. Fovea. What is the most peripheral part of the retina? What is the most peripheral part of the retina? Ora serrata. Very good. So I think you all have been attentive in the last class, or you might have studied retina. Some of you at least. I'm happy for that. In the next class, I'll proceed with hypertensive retinopathy and ROP. If you have any doubts in diabetic retinopathy, you can ask me today or in the next class, whatever is fine. In the next class, I'll ask few questions on diabetic retinopathy and we'll continue with hypertensive retinopathy and toxemia of pregnancy and also ROP, retinopathy of prematurity. Okay. So for today, you have no doubts on diabetic retinopathy, so I'm signing off. Thank you.